So, hi everyone, good evening and welcome to this lecture. It's a lecture in two parts. So first we're going to be covering medically unexplained symptoms and then moving on to cognitive disorders of old age, which are both part of psychology for medicine. It's a very important part of preclinical and clinical, but something for which revision is often left to the night before. So by getting ahead now, you'll save that last minute panic. So we'll start with medically unexplained symptoms. For those of you at Oxford, this is the relevant part of the syllabus. And there's also a mention of medically unexplained symptoms in the Introduction to Psychology section. So it's an important part of psychology. And we'll go through each of these points on a subsequent slide. So to start with, what's the difference between illness and disease? So illness is a subjective perception of change in the structure or function of the body that gives rise to concern. So more simply, it's what the person feels. It's important to remember that you can't determine what someone else feels, and so illness is when something feels wrong to someone. On the other hand, disease is an objectively observable abnormality in bodily structure or function, so it's what the doctor sees. And there's often a simple assumption made in medical practice that illness is due to disease, and therefore if someone feels really ill, you can do tests to find out the disease that is causing it. And while this is the case some of the time, there are limitations of disease in explaining illness. So disease is often an incomplete explanation for illness. This is exemplified by the fact that there may be illness with no disease, known as medically unexplained symptoms, or illness disproportionate to disease, such as an example that we will cover later of cancer and comorbid depression. So now, could you all go on to Socrative? And the room is Banks 7861. And this is the first question. Okay, so the vast majority of you got that right. And medically unexplained symptoms are a lot more common than you might think. They actually occur in 10% of medical outpatients. They're not usually found to be symptoms of disease. That's why they're known as medically unexplained. And generally, they do last longer than 6 months. So overall, medically unexplained symptoms are known to affect between 0.1 and 0.2% of the general population. It's been estimated that symptoms without any disease account for 10% of cases in medical clinics. And these include symptoms like pain, fatigue, breathlessness, and headache. Symptoms inadequately explained by disease have an incidence of about 30%. And there are a few studies to show this. So a study by Caton in 1998 found that medically unexplained symptoms account for over 40% of GP visits. Previously, in 1989, another study assessed how often illness can be explained by disease in primary care by observing 14 common symptoms, such as headache, chest pain, dizziness, and insomnia. It found that although 2/3 of cases underwent diagnostic testing, an organic cause was demonstrated in only 16% of cases. However, this was an American military study, hence it's skewed towards males and less likely to be representative of the general population. But similar studies have been done in secondary care. For example, one measured how often illness is accounted for by pathology in secondary care, and it found that 1/3 of cases are unexplained by disease, with unexplained cases arising particularly in neurology, gastroenterology, and gynecology. So what are medically unexplained symptoms? Psychiatry defines these medically unexplained symptoms using the ICD-10 or DSM-5 classifications of somatoform disorder or somatic symptom disorder, respectively. So somatoform disorders are multiple, recurrent, and frequently changing physical symptoms of at least 2 years' duration. The disorder course is chronic and fluctuating, and often results in the disruption of social, interpersonal, and family behaviour. A somatic symptom disorder is a form of mental illness that causes one or more bodily symptoms, which can include pain. The patient's symptoms are either in absence of or exceed those explained by disease, but they experience them as real and they may significantly affect functioning. A number of medically explained symptoms are often classified into a number of functional syndromes, for example, irritable bowel syndrome, pain syndromes, and chronic fatigue. Some argue that these are syndromes of somatic symptom disorder, but this is a highly controversial topic, with many patients resisting the idea that there could be a psychological component to their illness, largely because of the social stigma and misconceptions around mental health. However, some unexplained symptoms may be factitious, but this idea of malingering is very rare and may only be diagnosed with very strong evidence. However, in some instances, individuals will fake illness for personal, usually financial gain. Munchausen patients are distinct from these malingerers, as although they also present with factitious symptoms, they do so because of a psychological disorder. Okay, so going back to Socrative, which of the following psychological disorders is not strongly associated with medically unexplained symptoms? Okay, that's great. Almost everyone got that one right. So it's really important with these questions to read it really closely, because in psychology in particular, they often put questions with not in. So it's really important not to answer one that is. So what causes medically unexplained symptoms? If more than one factor contributes to being ill, there are biological factors, including disease. There are also psychological factors, and these include what the patient is thinking and what they're worried about. And there are social factors, which include what people say to the patient, and particularly important for us is what doctors say to them. So first, looking at biological factors, we know that disease is important, but not the only cause of illness. You can also change your biology by your behaviour. So the effect of behavioural change by bed rest is exemplified by an American space programme. People with back pain were told to rest and go to bed for weeks, but this has a huge effect on physiology. It resulted in postural hypertension, muscle wasting, a sense of well-being lost, and a loss of confidence. There are also physiological changes associated with pain and depression, including a sensitization to pain. Psychological factors also contribute to medically unexplained symptoms. These include fears, for example, hearing someone say, "My dad died when he got chest pain." Similarly, a low or anxious mood could lead to, for an example, an exaggerated concern about having a brain tumour. So anxiety and depression increase physical symptoms. There is also often a focusing of attention on symptoms, e.g. patients saying, "I always listen to my body." And this means that symptoms feel more prominent when you focus on them. Social factors causing medically unexplained symptoms include common beliefs in society, such that all chest pain is dangerous. Also what other people say, for example, "My son had that and he died." And also what doctors say, It's probably nothing, but it might just be a fatal disease. And this understandably makes people worried about their disease. Lastly, there is iatrogenesis, which describes doctor-caused harm that can contribute to medically unexplained symptoms. Harm can be caused by giving the wrong drug, putting someone in hospital for weeks, and by what you say to patients. Doctors can make people more worried about their symptoms, even by saying, keep an eye on that, and if it gets worse, then come back. So, a biopsychosocial formulation of illness allows us to summarize the contributions of the additional factors we've just discussed. So this is a quote from Engel, and he basically says that it's not adequate to consider illness from the sole perspective of pathology, and we've got to also look at the biological, psychological, and social factors. So this table, using the example of medically unexplained chest pain, illustrates how medically unexplained symptoms can be considered using this biopsychosocial formulation. So we can see that there are biological, psychological, and social factors, each of which can then be divided into predisposing, precipitating, and perpetuating factors, which can be seen as before, during, and towards the recovery stage of the illness. And this is a further example, which describes depression after successful cancer therapy, and it illustrates how illness disproportionate to disease can be considered using the same formulation. Disproportionate illness in people with disease is when individuals have symptoms to an extent not adequately explained by the level of underlying physical disease. This is thought to occur in about 30% of cases. And for example, there is a high prevalence of depression following successful cancer treatment, with patients still feeling physically ill, weak, and tired. This comorbidity of depression and cancer is another example of how additional factors, other than the pathology, account for illness. And there was a study by Walker et al. In 2014 that found the prevalence of depression in patients with cancer to be significantly elevated. 13% in lung cancer patients and 9% in breast cancer patients, compared to an estimated 4.4% prevalence in the global population. A further study in 2007 looked at the comorbidity of depression and chronic disease in men, and it found that a comorbidity of depression and any of several different chronic diseases resulted in a lower mean health score than either depression or the chronic diseases alone. The study also found that depression alone results in a lower score than many chronic conditions, demonstrating that it is a significant cause of illness. So why is a biopsychosocial perspective useful? Well, this perspective enables the directing of treatment by targeting all the factors involved in illness. Normally, treatment targets the biological perpetuating factors, but medicine has to address illness as well as disease, with illness being a combination of factors, which may or may not include disease. So the biopsychosocial perspective is useful for identifying the psychological and social factors with which we can intervene as well. For example, it might be useful to contextualize the health information, which is the predisposing social factor, and address the patient's partner's concerns. For instance, in the case of cancer and depression comorbidity, possible therapies could be antidepressants, mobilizing the patient to help alleviate mood disorder, and making it clear to the patient that the symptoms are due to depression, which is treatable. And there is evidence that targeted treatments, considering other factors, are more likely to be beneficial. Sharp et al. In 2014 found that patients with serious depression associated with cancer were 45% more likely to respond with targeted depression care for cancer compared to usual treatment. In more general terms, the best approach with medically unexplained illness is to convey to the patient that their illness is real, to offer positive advice and treatment, considering all the contributing factors, and to engage the patient in an active role in alleviating the often chronic symptoms. By considering other factors contributing to disease, we are more likely to achieve a better outcome. As Sir William Osler famously said, the good physician treats the disease, the great physician treats the patient who has the disease. And this is a distinction of great importance in ensuring the best medical practice. So now if we go back to Socrative, which one of the following terms couldn't be used in place of medically unexplained symptoms? That's great, everybody got it that time. So all the others could be considered medically unexplained symptoms, but in renal colic there is an underlying biological pathology. So now we've got a couple of past exam questions that are essays, but this content could also come up in the multiple choice questions. And you can see that with psychology, the questions are often very repetitive. So by looking at past papers, you can get a good idea of what will come up for your exams. So now we're going to move on to cognitive disorders of old age. So here's the syllabus, and you can see that it's another important topic. So first of all, what is normal cognitive aging? Cognitive decline is a normal part of aging. There is a spectrum from normal to mild cognitive impairment to dementia. And subclinical disease, such as minor vascular events, contribute to all of these states. However, not everything cognitive decreases. Whilst processing speed, working memory, long-term memory, and reasoning decline, world knowledge and semantic memory will keep on growing throughout life. Skill learning, such as the ability to draw what you see in a mirror, is also maintained, although it takes longer in older people. It's important to be careful in the way people are tested. Slower motor responses and deafness, for example, can affect older people's performance, producing an exaggeration of their cognitive decline. Brain atrophy is generally seen with aging, but some areas, such as the visual cortex, don't change with age. Other areas, like the caudate nucleus and the hippocampus, show a clear reduction, and these are most notably reduced in people heading towards dementia. There are three commonly reported brain phenomena in aging: overactivity in older relative to younger people, a hemispheric asymmetry reduction in older people, and a posterior-anterior shift with aging. In successful aging, older people have greater activity than young patients and less asymmetry than young people, whereas low-functioning older adults don't increase the activity or reduce the asymmetry. And it's not completely clear why, although there are several theories. It could be to do with compensation, i.e. the additional recruitment of neural activity to maintain performance, or due to a dynamic ongoing process of plasticity. So now we're going to look at how cognitive disorders of old age can be classified. So dementia describes a set of symptoms, including memory loss, mood changes, and problems with communicating and reasoning. There's also mild cognitive impairment, which is a measurable cognitive impairment, but with no or minimal functional impairment. There's no dementia, but 50% go on to a diagnosis of dementia. Parkinson's disease primarily involves motor deficits, although it's now recognised that a large proportion develop cognitive impairments, which can be described as Parkinson's disease dementia. This is usually mild, although it can be variable. Delirium describes an acute confusion, in contrast to dementia, which is more chronic. It's characterised by distractibility, restlessness, illusions, incoherence, and confusion, with symptoms arising quickly over a matter of hours or a few days. There's a huge variability in the impact of stroke, but people can go on to have impairments like dementia or aphasia or neglect. And finally, dementia. This is associated with many physical diseases and disorders and can cause cognitive impairments that mimic dementia. Now, if everyone could go back to Socrative, we've got some questions on dementia. So firstly, which of the following forms of dementia is not characterised by aggregated protein? Yeah, that's great. So it's vascular dementia, and we'll go through why that's the case in subsequent slides. But first, which of the following causes of dementia is most likely to be associated with visual disturbances and motor impairments? So that's a bit of a harder one, but it is Lewy body dementia, and we'll go through the key characteristics of each type shortly. One more question before we go back to the slides. Which cognitive deficit in dementia is most closely associated with the hippocampus? Yep, that's great. It is declarative memory deficits. Okay, so there are several subtypes of dementia with different underlying pathology, resulting in slightly different symptoms. So in Alzheimer's disease, we see amyloid plaques and tau tangles. In frontotemporal dementia, there are several subtypes, but the one to be most aware of is the role of tau. In vascular dementia, this is the one without the buildup of plaques, and instead it's caused by vascular pathology, most particularly stroke. And in dementia with Lewy bodies, as the name suggests, you get Lewy bodies deposited in the brain. And the extension material, for those of you in Oxford, wants you to consider where in the brain would be affected and how this links to the characteristics, which you can see in the table. So there are several standard neuropsychology tests for dementia, which can be useful in diagnosis. So the MMSE stands for the Mini Mental State Examination. The maximum score is 30, but we generally say mild cognitive impairment is less than about 27, and Alzheimer's disease less than 25. The mocha is the one that you're most likely to see in the Oxford Hospital. And again, the maximum score is 30, and the lower score suggests a greater severity of cognitive impairment. But because these tests are simple, they lack sensitivity, and a poor performance could reflect a lack of concentration or interest due to other factors like depression or poor education. Neuropsychology is important in differentiating between the subtypes of dementia. So in Alzheimer's disease, there's a primary episodic memory deficit, which means a difficulty in encoding new information. You see a steady decline in cognition. In frontotemporal dementia, there are several variants, but the semantic and/or the frontal deficits are primary. So this means that patients struggle with frontal tasks, for example, things like categories. And a particular problem that people with frontotemporal dementia would struggle with is if they were asked to tell you words beginning with a certain letter. So in vascular dementia, rather than a steady decline, you see a stepwise progression due to vascular events. And in dementia with Lewy bodies, there are visual hallucinations and fluctuating deficits, which differentiates it from Alzheimer's. So a past exam question on cognitive disorders of old age looks at the differences between the main types of dementia. And this is also an extremely common topic for the Part A multiple choice questions. So how common is dementia? Well, the incidence of dementia increases with age to 16% in those over 80. Delirium is also more common in the elderly. It has a prevalence of between 11 and 42% for elderly patients in medical wards. So now if we go back to Socrative, the question is, which of the following is not a risk factor for Alzheimer's dementia? So this is a trickier one, but majority again got it right. So it's really just a case of memorizing the allele this time. So alcoholism can be associated with dementia through the damage done to the brain. And as we've said already, old age is a risk factor. So what causes dementia? So age is a big risk factor. Dementia affects 1 in 6 people over 80. Genetics also play a role. There are familial patterns seen in Alzheimer's disease and genetic types of frontotemporal dementia. And certain variants of ApoE are associated with dementia. Women are more likely to develop Alzheimer's than men, which could be linked to a lack of estrogen after the menopause. Ethnicity may play a role, with some evidence that people from South Asia, Africa, and the Caribbean develop dementia more often than white Europeans. Lifestyle is also considered important, with smoking, physical inactivity, an unhealthy diet, alcohol consumption, and head injuries being risk factors for dementia. Similarly, delirium is more common in the elderly, particularly over 70. Dementia is the biggest risk factor for developing delirium. Severe medical illness, a history of previous delirium, and depression can also all contribute. And precipitating factors include adding 3 or more medications, the use of physical restraint, pain, surgery, anesthesia, and malnutrition. So now going back to Socrative, which of these is not required for a diagnosis of dementia? Yeah, that's great, because in dementia, communication might not be clear, as it's often impaired by the dementia. So now, which of these best discriminates between dementia and delirium? That's great. So with dementia, you tend to get a steady decline, while with delirium, it's more acute. So the clinical features of dementia are that it is a set of symptoms, including memory loss, mood changes, problems with communicating and reasoning. It's an umbrella term, as we've already seen by the different dementia subtypes. Diagnosis requires multiple cognitive deficits, including amnesia, a functional impairment, meaning the loss of ability to perform daily functions, such as dressing or going to the shops independently. It requires clear consciousness, so the diagnosis does not apply when the patient is unconscious. You need a change from the previous level, which is usually determined by talking to relatives, and a long duration, generally over 6 months. It is often caused by protein aggregation, such as amyloid plaques or tau tangles, which prevents the neurons from functioning properly and also causes neuronal death. The loss of the hippocampus in particular results in memory deficits. Dementia is quite different to delirium, although they're often confused. So in delirium, the symptoms arise quickly over a matter of hours or a few days, in contrast to the symptoms of dementia, which come on slowly over a period of months or years. Delirium is characterized by distractibility, restlessness, illusions, incoherence, and confusion. So how do we treat dementia? Well, in psychology, the interest is much more on the psychological aspects of treatment as opposed to the medical treatments. So we can use cognitive stimulation therapy, which involves taking part in group activities and exercises designed to improve memory, problem-solving skills, and language ability. And the evidence suggests that this does benefit those with mild to moderate dementia. Another option is cognitive rehabilitation, which involves working with trained professionals, such as occupational therapists, to achieve personal goals, such as using a mobile phone or another everyday task. This aims to use parts of the brain unaffected by dementia to help parts that are affected, and it can help people cope better early in the condition. We can also do reminiscence and life story work. So reminiscence work involves talking about things and events from the past, using props such as photos, favourite possessions, or music. Life story work involves the compilation of photos, notes, and keepsakes from childhood to the present day, and it can be in physical or digital book form. These approaches are sometimes combined and are thought to improve mood and well-being. So in delirium, the first goal of treatment is to treat the underlying cause, such as the acute illness, to address metabolic imbalances, to treat the infection, or stop the use of a particular medication. There are also secondary steps which can decrease the chance of recurrence, and these include promoting good sleeping habits, such as a quiet, dark room and uninterrupted sleep at night, and promoting calmness, so communicating in simple language, keeping familiar and favourite objects around, approaching the person calmly, avoiding arguments, minimising noise levels, and using comfort measures, such as reassuring touch when possible. So returning to Socrative, which feature best differentiates dementia and mild cognitive impairment? So that's great, the majority of you got it right again. So the main difference is that in dementia there's an impact on function, whereas in mild cognitive impairment there's an impairment in cognition, but it doesn't affect day-to-day function. In both we might see hippocampal atrophy on an MRI scan, and although the MSSE score is useful in diagnosing dementia, the tests are quite simple and not very specific. So it's more useful to look at how the condition is affecting day-to-day function. So comparing Alzheimer's disease and normal aging. So in most people, there is some degree of cognitive decline with age, but in others, the clinical threshold is met, leading to a diagnosis of dementia. And this is seen in the threshold hypothesis of 1986, where it was thought that all aspects of Alzheimer's disease pathology were seen to a lesser extent in normal aging, but Alzheimer's disease occurs when the normal aging passes a threshold. However, at age 85, virtually everyone has some neurofibrillary tangles in their cerebral cortex, yet not everyone develops Alzheimer's. There is an increased rate of hippocampal atrophy in those with Alzheimer's disease. People tend to lose about 1% per year of volume, but people with Alzheimer's can lose 5% or even beyond that. And the Optima study in 1994 used CT scans, which revealed that the average rate of medial temporal lobe atrophy was 15.1% in 20 Alzheimer's disease patients, compared to 1.5% in healthy age-matched controls, suggesting Alzheimer's is not a consequence of normal aging. So now we're going to look more specifically at the characteristics of Alzheimer's. So there's a primary episodic memory deficit, which means difficulty encoding new information, which affects life in many ways, such as communication problems, not recognizing safety hazards, and causing behavioural problems. There's the loss of hippocampal volume over time, although the rest of the brain is also deteriorating over time. We get something known as apraxia, aphasia, agnosia. So apraxia is the inability to carry out voluntary and purposeful movements. Aphasia is the difficulty speaking or loss of ability to speak. And agnosia is the loss of ability to recognize objects. The communication difficulties seen include trouble both in the production and comprehension of language. Many also lose the ability to read or interpret signs. Personality changes may occur, such as going from being quiet and polite to loud and ill-mannered, and frequent mood changes are also common. Behavioural changes include wandering, both at day and night, aggressive behaviour, and disorientation in time and space. So finally, other therapies for Alzheimer's disease. So current treatments are based on attempting to rectify the imbalances caused by the disease. They offer a mild cognitive benefit, but do nothing to prevent progression. One of the areas most affected is the cholinergic systems of the basal forebrain. Thus, drugs such as rivastigmine are used to enhance activity at these synapses, following the loss of cholinergic neurons. We can also use other drugs such as memantine, which are thought to reduce glutamate-mediated excitotoxicity. And hundreds of trials have been conducted on hundreds of compounds targeting a number of targets in the disease process in an attempt to find a disease-modifying treatment, although so far none have been successful, which has prompted much debate.